pretty much your clinicians, your RNs and LVNs that are visiting the patient can only have 12 patients. If they're visiting every other week, that's essentially 6 visits a week or something like that. So it kind of removes the concept of full-time clinical team, I guess, clinical staff. But anyways, that's that. Hi, everybody. My name is Mariam Treystman from the Home Health Consultant, and this is Title 22 Changes to Hospice Operations effective 6/22/26. So we recently did a webinar on the changes to the applications process, and so this is more about kind of day-to-day running the hospice and things like that. So let's get started. As we know, on June 22, 2026, the California Health Department came up with some new regulations. So who does this apply to? So we have CDPH licensed hospices in the state of California. Only hospice agencies, no other provider type. And this is part of the California moratorium to lift requirements. If an agency is accredited, then you're going to go by the more stricter kind of process of the two. When we say CDPH licensed hospices in the state of California, of course, if they are Medicare certified, then it still applies. Or if they're just licensed, this also still applies. So let's get started. So the first thing that kind of stood out to me, this is a tiny detail, but it was kind of a big deal, I thought. So pretty much there's one little detail to like inspections that has changed, and that's that surveyors can now review payroll records. So in like 20 something years of doing this, pretty much not seen surveyors review payroll records, and it was like not in their scope of practice to review payroll records. But the implication here is, first of all, they can confirm employment this way, and also they can confirm if you are paying people according to their requirements. There's a lot of rules in hospice and home health, but this is hospice, obviously. There's a lot of rules here about who can be W-2, who can be 1099, and so on. But previously, this has never really been checked in any kind of survey, inspection, whatever process. But now it can be. So I thought that was really interesting that they added payroll records to the list of items that they can survey on. So let's talk about who needs to be 1099 versus W-2 in these in like this kind of company. So first of all ownership needs to be W-2 and your management personnel excluding medical directors. So we have administrator, administrator designee, DPCS, DPCS designee, and your IDG core services. So these are the people on the IDG team. So we're like talking about the nursing, social counseling, and things like that. And then we have people that can be on 1099. So that is your physician or designee, meaning medical director and designee, and of course, miscellaneous disciplines. So home health aid, therapies, whatever. In extraordinary circumstances, we can, let's say, contract with nursing or contract from a core service, but there has to be some kind of special situation, like there's an emergency in the area, so now we need to quickly onboard staff and things like that. Before we started with the things that kind of everybody's like aware of, I just wanted to throw this out there because I think this is pretty critical. Again, they've never had the jurisdiction to do this, but now it is in the law. So please review your W-2 versus 1099 assignments, both against these kinds of rules, but also against the tax rules. You know, we're not really tax consultants in this way, but there are, of course, some like tax implications of how you categorize here or there. Next, we have geographic service areas. So this is actually more of an applications concept. However, I wanted to go over it in this operations video webinar because we haven't seen how this is applied yet. So the way that the law is written is that pretty much we are using these GSA calculations to determine where we can see patients. In terms of the law, they're just saying that this is how we decide approval or denial of a geographic service area. I'm sure everybody knows what a GSA is, or Geographic Service Area, but in case you're unfamiliar, this is the coverage area that you can see patients within. So there are rules that have changed to this, and rules change to this occasionally. Like, for example, a long time ago, there was a 50-mile radius. Then they made it a 2-hour or 4-hour driving kind of radius. This is around COVID time. They were approving like San Diego, all the way up to Fresno in some cases from LA County. Now there's again an update, and the update is that pretty much the nurse needs to be able to reach a patient within 2 hours of finding out that there's some kind of like issue, or the patient needs immediate assistance. So there's a whole calculation process. The reason I wanted to go over this in operations is because prior to now, when these laws came out, we've always been getting GSAs approved and things like that, but nobody was really looking at this, like whether it was CDPH coming out or any kind of accrediting body or even like Medicare kind of things. Nobody was really like looking to see if the patient fit in the surface area. This was all in terms of billing, in terms of surveys, like no matter how we were kind of operating, this was never something, it was like an honor system that like this was never really something that was checked. Now I believe it will be. So we are going to go over how to calculate a GSA, but we are still waiting on some kind of confirmation from CDPH if agencies need to like adjust their GSA, if during some kind of application process there's going to be a re-review of GSAs and things like that. So please stay tuned. We will cover this as we get more clarification. But at this point, at the very least, agencies cannot operate outside of their already approved GSAs. So I actually get this question a lot, like where people will say, "Oh, I got a patient in this, random area. I have full staff there. We can fully cover it and things like that, but it's outside of my GSA. It's like 5 miles outside of my GSA or whatever. Can we take this patient?" I mean, the answer has always been no, but now there's going to be some kind of verification process. I assume during surveys or, maybe during billing and things like that. Now that we have these new technologies, they can implement more details into the billing structure and things like that. With government, one of the interesting things that we've seen is that there might be 100 rules and they're like looking for 15 of them or 20 of them. The other 80 just kind of sit there until government decides what to do, like if they want to, check on them or whatever. So I assume that this is something they're going to start checking on because it's a whole section of the new law. But either way, please be aware that if you are changing your location, like you're moving your address, or any kind of like major change, maybe an ownership change or whatever, it is likely that in that application they will re-review your GSA. If you have originally been licensed with a big GSA, that might be a consideration for whether you want to move your office or not, because they will try to reapprove your GSA. So we want to make sure that we can cover, as much as we can, I guess. And there's no writing in the law that says that we have to recalculate. So unless we hear from the department that every agency needs to like resubmit GSA, we're just going to assume that whatever you're licensed for currently grandfathers in, unless we hear of something else, or unless you apply for something, now they're re-reviewing. So there's two concepts in the GSA. One, that a nurse can arrive within 2 hours of being notified that the patient has a emergency need or whatever. And two, to check if each county has an unmet need. If you're already approved for that county, then good for you. But this is a process we're probably going to have to redo essentially if you have an application. So when we are calculating, we have to use 4 samples. Pretty much what we are looking for is how far away the patient is from the office. So, some of you might feel like this is a little counterintuitive because, technically clinicians are not driving from the office. They're probably driving from their house or something like that. So this is something that you check to see from the office and not from like a clinician's home or something like that. So the office address that we are looking for is the one that's officially in your health department record. So when we do our 4-hour sample, we have to take each sample on a weekday, not on a holiday, between 7 a.m. and 9 a.m., and or between 4 p.m. and 6 p.m. Your documentation must show the timestamp and the exact date and time. So what we're showing here, let's go to the next section. We want to make sure the nurse can arrive within 2 hours, and we're using a tool, something like Google Maps or, another driving map kind of situation. So you take your address and you start to kind of, Google Maps it. So I'm just going to do this here from our address. So let's pretend that we're doing this from our office. So I'm going to see if we can go to San Diego in this time frame. Let's go to San Diego, California, and then we're going to go to depart at, and then let's say, Friday at 7 a.m. One kind of little tip I would do if I were applying for this is they want 4 samples, so I would just do like 7 a.m. and 7:15 a.m. versus 9 a.m. because it's much different at like 8:30 than it is at 7. But anyways, we have 2 hours and 10 minutes to 3 hours and 10 minutes for San Diego. So we cannot go to San Diego because it needs to be under 2 hours. So let's look at Laguna Beach. Now we're at 1 hour 15 minutes to 2 hours. And so what you would do is you would like print this page essentially, and you want to do this 4 times at different times. And what you want to do with this when you're establishing your GSA is essentially make these kinds of calculations all the way around the address to kind of find your average radius. So, and one little detail, if you do apps with us, we can definitely help you calculate all this stuff and figure it out. So let's take a look. So we're going to use a map tool, just like Google Maps. We're going to do this whole radius thing, like I was saying. And you have a little like blog or something like that, just like the one that we have on the screen right now, where we are trying to take the date of the test, driving hour test, the time, the address, the destination, the drive time, and the miles. Ultimately, once we get into a few things that are within 2 hours, at that point, what we want to do, take the 4 kind of mile numbers for each place that we're going, and then we want to divide it by 4. This is going to show us the average miles that we can travel in whatever direction, and that's going to give us our general radius. So that's how they want us to do the 2-hour drive time. But there is a second calculation that we would have to do, and that's establishing a need. When we are establishing a need, we have to establish a need as a single county that we're doing this for. So the practical implications of this, like for example, in LA County, according to these definitions of what a need is and things like that, I don't think, anyone's going to get approved for LA County anytime soon. And probably not in like the immediately surrounding counties. So if you are in LA County or an immediately surrounding county, I would definitely like do all of this prior to moving or, doing any kind of major applications because they will try to reestablish the stuff. So any county that you want to get approved for, we have to see if there's an unmet need. So we are comparing 2 numbers. First, how many people are likely to need hospice care in that county? And 2, how many patients the current hospices in that county can serve? If the number of patients that need care in that county are greater than the average number of patients that the hospices can serve times the number of hospices, then there is a need. If not, then there isn't. So let's kind of go and just do this. So first and foremost, they want us to go to California Health Department website and download the final deaths by year county. I'm going to show you what this looks like real quick. We are going to go into this report, and this report is the one that was linked in the slides, so you guys will have it. If you scroll all the way down, it's going to give you some filters. And I have the list of filters in the next slide, but I'm just going to kind of go over this. So first of all, you want to enter the county name of what you're looking for. Geography type is residence. Strata, you're going to filter for total population. And then the cause, you want to put CAN. That stands for cancer. And then you're going to search this. So you're going to just do a quick search, and it's going to give you this kind of report. So if you notice, this report has a bunch of pages and so on. One thing that they want us to do is they want to make sure that we're filtering for all years. So they don't want like this year's, they want all the years. There we are. So now if you notice, there was like 10 plus pages. So now we're at 5 pages. From there, they want us to add the count. So I'm going to come out of this spreadsheet now or this website and show you what that means. So here are the filters that we want to use. So years, all available years, the county is the county you're trying to check, geography type is residence, strata is total population, and then cause means cancer deaths. So what we're going to do is we're going to add everything in that count column, and then we're going to divide it by the number of years. So I'm going to bring this little thing back. So this is the count column right here. I don't know if you could see it. And then the number of years here is 10 years. So we're going to divide whatever that total number is by the number of years. When you do that, this gives you the average cancer deaths by year. You multiply that number by 0.7, and that's going to give you the non-cancer deaths. And then you're going to add those two numbers together, the cancer and non-cancer deaths. This is the number for all potential hospice patients in the county. Then what we're going to do with all potential hospice patients in the county is we're going to divide it by 0.5. So they're assuming that half of the total population is going to be eligible for hospice because, some people are not going to be eligible for this for whatever reason. And that's going to be the currently eligible hospice patients in the county. So we want to save that number, and then we want to get the second number, which is how many just general patients all of the hospices in that area can serve. So you're going to go to this website now, and it's the Cal Health Finder database. You're going to put the county name in the location. The facility types, you want to put hospice only, just hospice. And then you don't touch anything. It's all care and services for this, and then you go search. This is going to give you a number, so 1,229 in this case. That is the number of currently licensed hospice agencies in the county. From there, you want to multiply that number by 56 because they assume that every hospice can on average see 56 patients, and that is the current hospice capacity. Then you want to see which number is greater. Is it the number of average potential hospice patients, so that first calculation we did, or the number of the current hospice capacity in that county? If the number of patients is greater than the hospice capacity, then there is an unmet need. If the number of patients is less than, then there is no unmet need and you will not be approved for this. So that's how we calculate this GSA. If you guys need help with your applications to establish or get a GSA approval, please come to us. We can help you with the application process. But if you are just trying to see what you can cover and what you can't, that is going to be how you do it. The next section is going to be about hospice management training. This is a whole new section that they added in terms of kind of in-servicing and training for hospice management personnel, and there's several requirements here. Generally, hospices are used to having CT training requirements for licensed staff. All licensed staff need 12 hours of training, blah, 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 whatever, all this kind of stuff. Now we have to do this for our management staff. So, who does that include? First, that includes the administrator and administrator designee, then the DPCS and the DPCS designee, and then the medical director and the medical director designee. And there are 3 time points that we have to, 3, sorry, it looked like 4, 3 time points that we have to do these trainings at. First and foremost, we have something called first time hire. A first time hire means that this is the first time that this person is doing this position anywhere. So they've never worked as, for example, an administrator or DPCS or whatever, like as a management hospice, like one of these positions, ever in any hospice. So if this is their first time working as this kind of position in any hospice, then we have to do 24 hours of management training within 12 months of hire. Okay. Next, we have new hire training. When you have somebody that has just joined your organization, whether it's their first time or not being in that role, you have to do new hire training, 20 hours within 60 days of hire. And finally, we have annual retraining, which is 12 hours annually. So whether it's their first time, 83rd time, they're a new hire, they're not, we have to do the annual retraining, 12 hours annually. All of these time points count from the person's employment date, not a calendar cycle, unless that's how the agency does it. If you guys are counting this from the calendar cycle, then you still have to make the initial requirements. So, like, for example, if somebody was hired June 1st, the 24 hours for first time hire is due the next year, June 1st. But if you, let's say, want to do annual retrainings from January to December like this, then they have to hit their annuals for the year they're hired and the following year. Like, I guess what I'm saying is, you can't just say, oh, we do it by the calendar year and just wait 6 months since they don't have anything for 6 months. So you have to be at least as strict as the regulation. Okay, so let's keep going. So first and foremost, we have administrator and administrator designee first time hire topics. So a total of 24 hours of educational training in the management of a hospice, including but not limited to hospice operations, administration services, human resource management, personnel onboarding, hospice regulatory requirements, and hospice QAPI. Alternatively, they can do like a formal hospice certification program that covers a bunch of other things pretty much that are listed there. But long story short, they either get like a hospice administrator certificate or the hospice is responsible for covering all of this for first time hires, meaning they've never worked this position before. This is medical director and designee first time hire topics. So total of 24 hours of educational training in the clinical management of a hospice, including but not limited to 1, providing medical direction support for hospice patients and patients' family and representatives, B, effective leadership and communication, C, ethical and professional conduct, and D, hospice regulatory requirements. Or again, a hospice certification program. So when we talk about these things, like for example, it looks like it's just like A, B, C, D, like nothing, right? But hospice regulatory requirements, that's probably like a 6-hour or 7-hour training, right? Like you're going essentially through all the laws. So while it might be like a quick little like blurb here, it is quite extensive. Then we have DPCS and DPCS designee first time hire topics. So we have 24 hours in the clinical management of a hospice. So providing clinical direction and support for hospice staff, hospice patients, and patients' families and representatives, effective leadership and communication, ethical and professional conduct, and hospice regulatory requirements, or again, a hospice certification program. This is management new hire training. For management new hire training, it is the same for all the positions. So, for example, we gave like a sample new hire orientation guide kind of thing. But this is not broken down by like this is for administrator, this is for DP. It's not like that. This is just like everything that you need to go over. So we're talking about basic hospice services, personnel qualifications, responsibilities, administration, hospice governing body, administrator, DPCS, medical director, like pretty much what all the different positions do, how it all works together, exclusions check, contract oversight, emergency preparedness, infection control. So pretty much like we have to review the entire program with them, which is why they want you to do it in 20 hours, and you get 12 months to do this. So if we're hitting 1 to 2 hours a month, then we're gonna get to that within the 12 months. And then we have annual training. So again, this is for everybody together. It's not specific by position. And we have emergency preparedness, infection control, complaints, fraud, waste, abuse, patient records, controlled substances, and related policy updates. Then we have hospice admission, patient rights assessments, plan of care, coordination of care, live discharge, transfer, and discharge by death. If you are in the compliance program, these are topics we're going over in the in-services generally anyways. So just FYI, we're like reviewing that stuff anyways. One little detail about all of this that is not on my slides, but it's kind of the rule, is that the supervisor in your agency needs to sign off on all of this. So just FYI, there's like, there's kind of like requirements for people signing off. There's competency requirements and things like that. It's not just like, oh, we're just going to sign an in-service form. Like that's not the only documentation requirement you have. There has to be competency assessments, testing, whatever, things like that. And here we are. Here's the training documentation. First and foremost, we need name of the training or certification program, the name of the participant that attended the training or certification program, a description of the content, name and contact information of the entity that provided it, the name of the instructor who provided it, the hours and dates the participant attended the training, and a completion certificate for the training or certificate program signed by the participant and the participant's supervisor. So that's kind of like what we're talking about here. So if you are in our compliance program, we're going to be giving all of these resources and just like the forms that need to be filled out and all of this stuff to anybody in the compliance program, including the content to train. We should have, it's currently being completed for development. So by January 1st, 2027, you should have full content to be able to train on, especially as it relates to the compliance program. So if agencies are in the compliance program, they're training on their actual processes and not just like, oh, here's like some policy from a policy book. It's going to be, specific to the other things that we're doing in the compliance program. All right. And the third kind of big change here is the patient acuity system. So this is under the nursing section of that law. And with the nursing section, you have a couple of like details. First and foremost, this the big kind of like shockwave that hit the industry was that they don't want nurses specifically to have more than 12 patients at any given time. When we say more than 12 patients, so the actual terminology in the law is assigned to more than 12 patients. And when we say assigned to, what we mean by that is that this is their nurse. It's not like you're just jumping in for a minute. It's like this is the nurse assigned to the patient. So that can be an RN or LVN. And in hospice, right, we have RN going 1 week, LVN going the other, RN going 1 week, LVN. So when we are, obviously, there might be more visits than that, but more or less, this is kind of the setup. So let's talk about this 12 patients or less per nurse. Obviously, like outside of just like presenting the rule, this feels like not how the industry works, I guess. But okay, it's okay. This is what it is. So pretty much your clinicians, your RNs and LVNs that are visiting the patient can only have 12 patients. If they're visiting every other week, that's essentially 6 visits a week or something like that. So it kind of removes the concept of full-time clinical team, I guess, clinical staff. But anyways, that's that. When we are creating these like ratio calculations, we can only use nurses for the count that are assigned to patients. So if you have nurses in your office that don't do any patient care and are just kind of like QA reviewing or administrative staff, like your DPCS, but they're not assigned to any patients, they cannot count into this count. So it has to be like literally your visiting nurses only. So please go back to your office and just start looking at that. Um, Again, we haven't seen how this has been enforced in any kind of survey scenario yet. So once we have any more information on that, we'll let you know. But this is the rule. So they also want policies and procedures implemented to determine staffing for on-call nursing services for an RN to appear in person to perform nursing services within 2 hours of receiving info that a patient has a medical need or safety concern, and for how on-call nursing personnel must contact hospice management personnel for after-hours assistance. If you are in our compliance program, we have this policy and procedure already implemented. Of course, you can make adjustments based on your agency's requirements and stuff like that, but we do have a policy for this. And finally, we have develop a patient acuity system. So that's a whole thing. Let's jump into it. First and foremost, for the patient acuity system, we have to assess the patients for their acuity during different time points. So at admission, during the development of the initial and comprehensive plan of care, at each IDG or review, or IDG review or plan of care update. By the way, this is a very critical slide because when we're saying we have to assess this, we need documentation for all of this. So just like FYI, this is a lot of times we have to assess the acuity. When there's a significant change in condition after hospitalization, emergency room visit, transfer, fall, injury, medication issue, wound issue, behavioral concern, or safety. So pretty much anything that happens, we have to reassess acuity. When the patient or caregiver requests increased symptom management or support, when there are 2 or more after hours calls within 7 days, when caregiver availability or ability changes, when patient appears to be transitioning or actively dying, when nursing visit frequency is increased or decreased, and when management, the assigned nurse or IDG determines that this is needed. So pretty much like all the time we're reassessing the acuity system. So if you notice, this is review sample policy. So let's do that. So we do have a sample policy for this, and let's go into it. So here are some of the elements that need to go into your assessment. First and foremost, we have acuity scoring tool and criteria. There are four scorings, but it starts at 0, so 0 to 3. 0 is no current concern or minimal need. Then we have 1, mild need, stable routine monitoring required. 2, moderate need, increased monitoring or intervention required. And 3, high need, unstable, complex, or frequent intervention required. We have stage and severity of terminal illness scoring, specialized equipment or technology scoring, complexity of clinical judgment, patient self-care and caregiver support, licensure level required, meaning the licensure of the clinician, risk of patient injury or safety event, developmental cognitive communication limitations, specialized treatments, weekly requests for symptom management, psychosocial, behavioral, or neurological needs, and so on. So when we're doing this, we're using all of those elements to create a general score that will then, determine what kind of level of nursing they're going to need. There are some overrides, meaning there are certain situations where you just need to go all out. So patient is actively dying and requires frequent nursing assessment, uncontrolled pain or symptoms despite current interventions, 3 or more symptom management requests within 7 days. So these are all kind of like the exceptions to, I know you're scoring, I know we're doing all these scoring things, but we need to just get to the patient. We don't have time to do 2 hours of scoring. We're just going to get quickly to the patient during these kinds of situations and just provide care immediately. So they want to create a flexible system where, yes, we're using, kind of more data driven things to make decisions, but when a quick decision is needed, that we have systems for that as well. And then this is how we are determining nursing care requirements in caseload weighting. So this is something um, really important. And so it says, although no licensed nurse may be assigned more than 12 patients, the hospice should also consider acuity weight when assigning caseloads. The hospice should attempt to keep each licensed nurse weighted caseload at or below 12 weighted points when possible. So the whole point of this is you might have a patient who needs like daily care versus a patient that needs to see you once a week. They're kind of like fine for now. They're stable, fine. They're stable. They're kind of okay. The whole point here is that the nurses are not too busy to take care of anybody on their caseload. And then, of course, we have additional personnel assignment. This is things like PRN visits. This is also additional kind of alternative things. And of course, we have an after hours escalation, which is part of the policy requirement that they wanted. So that was our sample policy for the patient acuity system. It would take like 2 hours just to go through all of this. Like it needs its own webinar if we're going to go into detail about it. But if you're on the compliance program, this is something we will be helping you implement in the coming months. So how are we addressing this? GSA kind of determinations we can help you do during any kind of application. So if you're doing a location change application with us or like whatever else and it requires GSA determination, we can definitely help you with that. It will be part of the application fee. Management personnel training, if you're on the compliance program, you're going to have policies, schedules, and resources now, and then trainings available starting January 1st. So like kind of a more detailed that you can like really, really, use this for. And for the patient acuity system, we're providing policies and procedures, providing forms with instructions and examples, and detailed trainings with examples. So we're doing monthly webinars on the compliance system. The next, this month's is how to read the Pepper report for home health and hospice. It's going to be separate webinars. But the following month for hospice, we'll be addressing the patient acuity system first and foremost, and then kind of going around the others. GSA, like I said, I think this is more application based. If you're approved for certain areas, you're approved for now. They haven't said anything about having to like reapply GSAs or anything like that. So we're snoozing on this for now until we have some kind of feedback from CDPH. Management personnel training. Luckily, we have 12 months to address these things. So we will be addressing it through the compliance program, just like we have other in-servicing kind of materials for you there. And the patient acuity system, of course, is next month's webinar topic for the compliance program, where we're going to go into detail about implementing this within your agency. So now what? If you need help, please contact us, sign up for the compliance program, and we will help you implement these processes and make sure that you're set and ready to go. If you have any questions, please email us at info@thehomehealthconsultant.com. Our office phone number is 877-406-9727. And please follow us on social media for updates and things like that. And of course, as you know, I make videos, informational videos and stuff like that. So thank you so much for joining us today. This was the operational side of the Hospice California Title 22 updates. My name is Mariam Treystman. This is the Home Health Consultant, and please contact us if you are interested in compliance services. Bye.